It's Dr. Chappuis from Spine Center Atlanta. I'm an orthopedic surgeon. I subspecialize in adult spinal disorders. And we're here today to talk about lumbar spine surgery. You know, we hear so much about this, including lumbar fusions. And so I thought before we get into the specifics of a given operation, we talk first about the spine. There's three components to the spine: the cervical spine or the neck, the mid-back or thoracic spine, the lower back lumbar spine. Most problems for patients are in the cervical, neck, or lumbar spine. Now, when we talk about this, we're mostly talking about degenerative type conditions, because there's other conditions such as deformity or scoliosis, trauma or fractures to the spine, tumors from cancer. That's a whole different group of patients, and surgery tends to be more indicated in those patients than in the degenerative spine. Now, if we look at all of spine surgery, 80% of spine surgery is done for degenerative type conditions, which include disc herniations, which I think we're all familiar with. The other 20% are for the conditions I mentioned earlier. So now as we hone into the degenerative spine, what are reasons to have any surgery? I mean, no one wants an operation. When is an operation indicated? Well, first of all, most cases should be treated conservatively with physical therapy, chiropractic care, injections. But then what are the absolute indications for surgery? Really, there's three. One is loss of bowel and bladder function. So if you have a big disc or a spur that's pushing on the end of your spinal cord and it affects your bowel or bladder function, that's an indication for emergent surgery. The second is what's called a progressive neurologic deficit. That means if you've got weakness in one of your legs and that's getting progressively worse, that would be another indication for emergent surgery. The last, which is the biggest category, is intractable pain that hasn't responded to conservative care. And that basically means you're having pain despite all these other conservative conditions. And the question I always ask my patients is, does the pain affect what you need to do, your job, your family? Does it affect what you want to do? And if the answer is yes, it is, then we start talking about surgical options. Always with surgery, you want to start with the least invasive and then move to the more invasive. And with patients, I try to explain the least invasive, the potential problems, complications, success rates, to the more complex procedures and what the risks are there. I think over the past 20 years, we've all been excited about nuances in spine surgery. And there's been a lot of spinal fusions or lumbar fusions. When your surgeon talks to you or your doctor talks to you about surgery, I think the question you have to ask yourself, and he should be asking you, is it primarily back pain? Is it primarily leg pain? Is it back and leg pain? The other question is, have you had previous surgery? And once we kind of look through all those, then if it's primarily leg pain, and we just finished an operation where we actually open the nerve roots. It's called a Laminoforaminotomy. And these are the nerve roots here. This is the lamina. So we open the lamina. This is the neuroforamen where the nerve comes out. So we basically burred and opened the neuroforamen so the nerve had more room to breathe. So that's a very good operation if you have primarily leg pain. Also, leg pain can result from a disc herniation. An example of that is right here. This herniation can push on one of the nerves and cause primarily leg pain. If those are your main symptoms, in my opinion, a fusion or more aggressive surgery is not indicated. It's really just an operation where you want to free the nerves up to help the leg pain. Now, if it's primarily back pain, an operation that we're talking about here is not usually helpful. And in that case, the question I think we have to look for is, where is the pain coming from? And we call that a pain generator. Is it coming from the disc itself, which is known as discogenic pain? Is it coming from the facet joints in the back, which would be facet-mediated pain? And these joints are just like your hip or your knee. They're diarthroidal, which means they have cartilage on them, and they move just like your hip or knee joint would move. As they lose cartilage over time through the degenerative process, they can become painful. Now, if that's the case, there's a procedure called medial branch block radiofrequency ablation. That's a percutaneous procedure that can be extremely helpful, and it's not surgery. Now, if that's helpful, but the pain comes back, it can be done a couple of times per year, but if ultimately it keeps coming back, then we're looking at the possibility of a fusion procedure. Also, if you have pain that's discogenic, which means it's coming from the disc itself, the best way to treat that, if you get to the point of needing surgery, and again, we'd want to make sure that this condition was treated conservatively for a good period of time. And I would not even consider a fusion in a patient like that for at least a good year after seeing them and treating them conservatively. If they get to the point though where now the pain is so severe it's affecting their activities of daily living, then the question is, what's the best procedure? The fusion can be done from the front through the stomach, called an ALIF, or Anterior Lumbar Interbody Fusion. It can be done from the back, called Transforaminal Lumbar Interbody Fusion with pedicle screws. It can be done from the side, which is known as a Transpsoas Approach, and then with backup pedicle screws. Any of those are acceptable options for discogenic type back pain. We prefer the anterior approach, or anterior lumbar interbody fusion, because it doesn't leave screws in the back and it minimizes having to move or touch the dura. And anytime you're retracting or touching the dura, which is the sac on the back part of your spine that carries your nerve roots, there's a chance for scarring. Also, by going from the front, we can correct the lordosis, which is the curvature that we have in the back. There's really 3 C's. The neck has a reverse C curve, the thoracic spine has a C curve, the lumbar spine has a reverse C curve. As we degenerate and the disc collapses, we lose some of that lordosis or curve. So by going from the front, we can actually open this up and create more lordosis. Also, if the disc is where the pain's coming from, then by eliminating all of the disc, then you're going to take away one of the sources for pain later. Now, another option that's become available over the past few years is lumbar disc replacement, and that's where it's done from the front. The disc is cleaned out. Once the disc is removed, then rather than a fusion, the actual disc replacement is placed in there. There's a number of discs out there from different companies, so I won't mention any one in particular, but they usually involve polyethylene or plastic type insert with titanium end plates. So that's put in and it maintains motion. It's a good alternative to a fusion. The problem is, if those happen to fail and you have to go back in from the front, sometimes that can be problematic because the great vessels run down in the area where this surgery would be, and so sometimes it can be problematic. But there are a number of these that have been done. It's a good alternative. We're doing a number of these in the cervical spine. That's an alternative to a fusion. So in summary, no one wants a back operation. If someone's suggesting one, you really want to make sure you've done all the conservative work. I would strongly suggest a second opinion, because there's different surgeons that do different procedures. And then do your homework. When you get home, look up the operation that was ssuggested to you. The good news is we've got the internet now. You can look up that operation, you can look at the success rate, the complications. So that's really it. It's a very helpful. Spine surgery, back surgery, and fusions can be extremely helpful, but we want to make sure that things don't end up worse than what we started. And when that happens, it's called failed back surgery syndrome. We don't want to go there. So hopefully we can get to the exact source of the pain, and if surgery is indicated, we can identify the exact pain generator and treat that. Hope you all have a nice day.